I would like to introduce to you today's speaker, Dr. Charity Oyedeji. Charity Oyedeji is an assistant professor in Duke University's Division of Hematology. She completed her training in internal medicine pediatrics at the University of Rochester and completed hematology fellowship at Duke University. Her research focuses on sickle cell disease and aging, with a special focus on developing tools and interventions to measure and manage physical function in older adults with sickle cell disease. She has received several awards through the American Society of Hematology, ASH, and the Duke Center of Aging. Her work is funded by the American Society of Hematology, the National Institute of Aging, and the Duke Center for Research to Advance Healthcare Equity. And with that, I will turn it over to you, Charity.
Thank you very much. And hello, everyone. Today, we're going to be talking about aging and sickle cell disease. And I'm just going to move this over. All right, you can go to the next slide. I have nothing to disclose. Next slide. The objectives for today, we're going to talk about sickle cell disease in the older adult. We're going to talk about the functional assessment tool that we're developing called the Sickle Cell Disease Functional Assessment. We're going to talk about measuring frailty and our Sickle Fit study that is ongoing. Next slide. The life expectancy for sickle cell disease, fortunately, has improved substantially, really over the last 50 years, due to a lot of innovation, things like newborn screening, penicillin prophylaxis, hydroxyurea. All these things have led to prolongation of life. However, it did cause us to have a unique issue now that people are living longer. What are we going to do? How are we going to manage people, right? We can't treat older adults like children, right? The same way we treated children. We can't treat older adults like we treat young adults, because there are unique issues that happen as people get older. And so this is the importance of the work that we're doing now, is figuring out how do we manage, how do we measure physical function and some of the other areas of functioning and preserve and prolong life and quality of life. Next slide. So let's talk about sickle cell in the older adult. Next slide. So we began some of this work with the mentorship of Dr. J.J. Strauss and Marilyn Tellen by looking at patients in an existing cohort. So the OMG, outcome modifying genes on sickle cell disease cohort, which is a cohort at Duke, UNC, and Grady and Emory. And this is a large cohort of about 700 patients that we wanted to look at the differences between younger and older adults to really understand what are the unique challenges, what are the unique conditions that happen in older adults compared to younger adults. And so in this study, we defined the older adult as being age 50 and older, and the younger adult as age 18 to 49. Yeah, next one. And what we found when we compared patients in these two groups is that older adults tended to have a lot more chronic complications. So, being older, you live long enough, you can collect and acquire a lot of comorbidities. And so things like pulmonary hypertension, where it was more common in older adults, leg ulcers, avascular necrosis, so needing hip replacement was a lot more common in people that were age 50 and older. Heart failure, retinopathy, and the other thing was renal disease. Renal disease was, as has been time and time again shown, that as you get older, your risk of renal disease, proteinuria increases with time. And so these are some of the challenges and unique characteristics that we're seeing in older adults. Next slide. The other thing that we found was that as people were older, to the older adult group, they actually were less likely to have been hospitalized. And so, when we compared opioid use, long and short acting opioid use between the two groups, they were similar. But when it came to hospitalizations, older adults had less. So with 48.3% of older adults versus 60% of younger adults being hospitalized. And so, one of the things that we think is that as people got older, their ability to self-manage their crises at home, so being able to, the strategies, the wisdom, the knowledge that they've gained over time had allowed them to be able to stay out of the hospital despite still taking the same amount of opioids that the younger adults took, as far as like short and long acting. And so this showed us that the older adults had some unique knowledge that maybe some of the younger adults also may benefit from as well, that allows them to stay out of the hospital. Next slide. So when we compare what we know about people with sickle cell disease to the geriatric population that doesn't have sickle cell disease, we find that there is a lot of unique characteristics in people with sickle cell disease, such as things like the shorter life expectancy compared to geriatric populations that don't have sickle cell disease. People with sickle cell disease have a unique thing called a vaso-occlusive pain crisis that people in the general population don't have. They have AVN, pulmonary hypertension, a specific type. Functional asplenia is unique to people with sickle cell disease. But there's an intersection, there's overlap of things that are very similar between people that are older with sickle cell disease, or people just with sickle cell disease in general, and geriatric populations. And so things like functional decline happens in people with sickle cell disease pretty early. And this is a big issue that geriatric populations have been studying for decades. So how to measure and manage functional decline. Cognitive impairment is something that is similar in both groups. Silent strokes, the increased risk of myeloid cancers like MDS, leukemias, they're increased in people with sickle cell disease and in geriatrics. Visual and hearing impairment, something that's really underappreciated in sickle cell disease, but is widely studied in geriatrics. As I mentioned, renal disease, joint replacements, chronic pain is huge. Elderly populations really have chronic pain as an issue, and it's something that has been studied extensively in sickle cell disease. And VTE, venous thromboembolism, so blood clots in the lungs, legs are common as people get older. And so if you think about, and depression as well, depression is something that older adults in the general population deal with, and people with sickle cell disease deal with across the lifespan. And so, if you think about someone who has sickle cell disease and they're at a geriatric age, so imagine kind of like all of these things you see on the screen being something that they have to deal with. And so understanding that there are a lot of things that overlap with geriatrics, some of the tools that are used in geriatrics can be very useful in measuring, assessing, and also managing people with sickle cell disease. And so we've used a lot of geriatric tools in our research program. Next slide. So one of the studies that I did a few years ago was I was interested in understanding what are the unique experiences of people with sickle cell disease when they go beyond age 50. So what are their experiences like? How do they experience aging, right? And so what we did was a qualitative study. So usually, when you don't know a lot about a topic, it's always good to really start with asking the population of interest, like, what are your experiences? How are you living with this? So we interviewed 19 people age 50 and older at Duke, so just a single center. And this was a descriptive qualitative study where we did semi-structured interviews. Most of them were done by phone, and most of them were done in person. And I personally did all the interviews. I asked them open-ended questions about their experience. So what is it like living with sickle cell disease, aging with sickle cell disease? What is it like surviving beyond the life expectancy? If they told you when you were younger you weren't going to survive, what is it like going beyond that age? And what kind of factors do you feel have contributed to your longevity that have allowed you to live beyond age 50 and older? So these interviews were audio recorded and they were transcribed by a transcription service. And the interviews, some of them were almost 2 hours long. So they range from 30 minutes to 114 minutes. And we analyzed it using a method called conventional content analysis. And with the help of a qualitative expert, we analyzed this data. Next slide. And one of the biggest questions that I found very interesting that I asked them was, what is the single biggest problem you are facing with sickle cell disease? Because I really want to understand what are the biggest things that you're dealing with in your age group. And so we got a variety of different answers to this question, but one of the most common answers was how sickle cell interferes with the ability to work, right? People really wanted to continue to work, and they found joy in the ability to continue to work. So when they weren't able to do that they considered that to be one of the biggest problems they were facing, beyond having, being hospitalized, having pain crises, just the ability, not being able to do the thing they want to do, physical limitations. So this not being able to do, and physical limitations could be, like I can't drive in the car to the beach for a long time like I normally used to do. And so not being able to stand for a long time or whatever the case. So a lot of things surrounding the physical abilities. People talked about pain. They talked about how the lack of energy, the lack of juice, the lack of the fatigue also contributed to these limited abilities. And it really just came down to, I cannot do the thing that I want to do, that really brought me joy previously. People talked about multiple health issues that started rising up as they got older. So as we saw in the bigger study, the multi-center study, that there are comorbidities that accumulate as you get older. And so these were the things that some patients found to be big issues. People talked about mental health issues and social isolation that was underappreciated and underdiagnosed. And several people talked about how they felt like the providers were not knowledgeable about how to care for them at their particular age, and that they felt like there needed to be more research, there needed to be more data on how to care for them as an older adult with sickle cell disease. Next slide. So one of the other themes that we learned from this section of these 2-hour long interviews was that patients, as they get older, people as they get older with sickle cell disease, they gain lots of knowledge about how to care for themselves, which is not a surprise, right? You live long enough with a disease, from birth, you're going to gain a lot of wisdom over time. And they talked a lot about how that differed between when they were younger versus when they were being older, and all of these strategies that they gained over time that really helped to manage their disease and prevent them from even having complications in the first place. And so you can click. So this participant talked about some of the factors that they help, some of the wisdom that they gain, and the factors that they help that improve their longevity. So this person states, I think part of that is to be a good steward of my body, eat responsibly, exercise, and not endanger the body with poisonous materials such as alcohol, drugs, and stuff like that. And that participant also really talked about even spirituality along with this as well, as being things that helped to improve longevity and quality of life. And so really just thinking about this multifactorial part that really helps to improve longevity. So this next participant also talks about similar things. So he talks about exercise, exercise, diet, drinking lots of water, and doing mindful things, meditation. All those things, I think, together gives you a good quality of life as well as a longer life. So, asking them about these factors that contribute to longevity, all these things together. So this multi-pronged approach that really helps, and really not forgetting about the mental aspect of it. Next slide. And so a wide response was talking about modifications, really knowing how to adjust your life and knowing your limits. And this was one of the biggest wisdom that was gained in the 50 and up group. This participant states, I just let my body kind of tell me what I could do and not do. And I guess after you have experiences like that, you learn how to make adjustments for life so you can still live life and do things other people do, but in a more reserved and a wise manner. And this really just captures, the wisdom that's gained as these people have gotten older to age 50 and up, and really just learning how to kind of adjust their life so that they can still be happy and do the things they love to do and feel normal. And so, this is what I hope that some of the older adults will be able to share too. So let's talk about the sickle cell disease functional assessment tool. Next slide. And so the sickle cell disease functional assessment tool, like I said, is a tool that we've been developing to assess multiple areas of health. And it is based on a geriatric assessment. And what a geriatric assessment is a multi-dimensional way of measuring someone's abilities in different areas of health. So looking at functional status, your cognitive function. So what is your memory like? What psychological state? Do you have anxiety, depression? Social support, what is your family support like? What are your comorbidities? What's your nutrition like? What are your medications? And the reason why is because a lot of times we miss a lot of these things in our routine clinical visit. Next slide. And so some of the reasons why we would use a geriatric assessment of sickle cell disease is because it detects the vulnerabilities that we miss by routine evaluation. So like I said, in a typical clinic visit, which some of you are probably familiar with, you sit in clinic, and a lot of times we end up talking a lot about maybe a complaint. Maybe there's like, I'm having a lot of back pain. You spend a lot of time talking about that, but then you never really get to the preventative stuff. You may not get a chance to spend a lot of time on some of these. How can we capture these unrecognized parts of you that, if we were to address, may improve your quality of life? Right. And so the other benefit of doing a geriatric assessment is that it has been shown to predict survival in adverse events. So it helps us to understand, what is this person's risk of a future adverse outcome? So if I measure all these different areas, I can come up with an idea of how at risk this person is of something bad happening to them in the next few years, and I can come up with a multidisciplinary management plan that can address some of the areas, some of the deficits I may identify. And so that's what the red box is talking about, identifying intervenable areas that we can actually address to improve quality of life. Next slide. So we did a pilot study measuring using basically a geriatric assessment. This was a geriatric assessment for sickle cell disease that we called the sickle cell disease functional assessment. And we still call it that now. We probably should come up with a better name at some point. But it's the sickle cell disease functional assessment. And the reason why we called it that is because people in our 50 and up group did not like the word geriatric, and they felt like they didn't meet criteria for that yet. So we stuck with just the functional assessment, which is fine. I respect that. So we took 40 participants, 20 younger adults, age 18 to 49, and we took 20 older adults, age 50 and up, and we used that young adult group as a comparison group because we really wanted to understand still the differences between this group and the unique, issues that the 50 and up group experienced that were different from what the younger adults had. We did this in just a single center. We did this at Duke, and we excluded people that weren't fluent in English because all of the measures that we were looking at were in English. We excluded people that were wheelchair bound because there is a requirement for them to do some walking, some physical performance testing, and we excluded people that had that severe cognitive impairment that couldn't consent themselves because it's a research study and we wanted them to be able to agree to it themselves. We collected demographic data, so their family history, their smoking history, their socioeconomic stuff like that, their medical history, so what kind of non-sickle cell complications they have, what kind of sickle cell complications do they have, and we collected their laboratory data. Next slide. And looking at the characteristics of the group that we assessed, this is just baseline characteristics of the participants in the study, and we see that the younger adult group had a slightly higher hemoglobin by about 1 gram, and that's actually not surprising. So as people get older, we do expect their hemoglobin to decline to some level because even just aging itself causes the hemoglobin to go down, and part of that is that the bone marrow, as it ages, it can sometimes get exhausted, so you can have some stem cell exhaustion that happens, and also you have more renal disease as you get older, and that can also make your hemoglobin go down as well. And so we're not surprised that older adults were slightly lower than that area. There were similar people with severe genotypes, so SSS beta 0. Quite a bit of people were on hydroxyurea in both groups. A few people were on chronic transfusions. And then once again, what we found here is that the older adults tend to have a bit more of the chronic complications like eye disease, like retinopathy, AVN. Older adults, both groups needed some joint surgeries. And then the chronic kidney disease was more common in the older adult group. And the younger adult group were once again hospitalized more than the older adult group. Next slide. And one of the most interesting findings that came out of that study was, and I'm just going to orient you to this graph, and some of you may have seen this, some of you may have not, but just to kind of get you oriented, that this basically is a measure of different areas of your physical performance. And so gait speed is basically how fast can you walk. If I give you a 3-meter course, how fast can you walk at your usual gait speed? And gait speed is used widely in geriatrics, and it's a very, very powerful measure of someone's overall health. So a person who has a slow gait speed, someone who walks slowly, is more likely to end up institutionalized in a nursing home, and they're more likely, they have a higher risk of death, in the geriatric literature. And so slow gait speed, is a very important tool, and it's a very quick measure that can tell you a lot about someone's overall health, at least in the geriatric populations. We don't know how useful a really gait speed is yet in people with sickle cell disease. Timed up and go here, which is a measure of, I guess you can't see my mouse, but timed up and go is a measure of how can you get out of a chair, can you walk to a cone, walk around the cone and sit back down. And that's measuring your balance. So can you balance can you do this without falling? And so a person who takes longer than 12 seconds to do that is a higher risk of falls. And so it really tells you a lot about someone's fall risk. 30-second chair stand is a measurement of your lower body strength, and it's how many times can you get up out of a chair and sit back down as quickly as you can in 30 seconds. And just really just looking at your lower body strength, which is something you need day to day, like getting off a toilet, right? You need that lower body strength to just get up, get out of a chair if you're sitting down all day, right? And so then the 6-minute walk is something that people are very widely familiar with in the sickle cell literature, and that is a measure of your aerobic endurance. Is used for pulmonary hypertension screening, and it's something that we're very familiar with in sickle cell disease. Really, the only one of these that is really widely used already in sickle cell disease, and really that's just the distance that you can travel in 6 minutes, moving as quickly and as safely as possible. And so what we found is that the actual scores, which is the column, the second column here, the actual scores were much less than the expected performance for their age. And the mean age, this is just the people over 50 and older, that had a mean age of 57 with an age range of 50 to 71. And so we, compared them to people that are in their 60s, because 57 close enough to 60. So we wanted to see how do they compare to people in the general population age 60. And we found that the people age 50 and older had physical performance that was very similar to people in their 80s. So even though they were around 50, 60, they were performing as people in their 80s in the general population. So this was kind of a signal that there is some accelerated functional aging that was happening in people with sickle cell disease. Now, what is the significance of that? It's not quite clear, but we know that that's a sign that there may be a need to improve their function. Next slide. And we did the same thing for people age 18 to 49, so the younger adult group. And we found, surprisingly, that even the younger adults also had accelerated functional aging as well. So even though, the mean age of the young adult group was 30 with a range of 20 to 47, they, for their gait speed, so I told you gait speed is a really powerful measure of overall health, they were performing still like people in their 80s. Right, the timed up and go, they were performing like people in their 70s. As far as lower body strength, was similar to people in their 60s, and also the 6-minute walk, similar to people in the general population in their 60s. And so this also is a sign that there is some accelerated aging, and that maybe we should also be thinking about intervening before 50. Maybe waiting till 50 it was a bit too late. And so, that actually even prompted us to adjust our definition of our older adult. Right, we ended up moving that back down to 40, and probably we need to even go lower, but calling that 40 since this study. Next slide. So this was just looking at gait speed in a different way, right? And so this just allows you to kind of understand more of it in a practical way. So, in order to cross an intersection, right, a typical intersection, you need to be moving at a speed about 1.2 meters per second. That's represented by this green line on the graph here. And everybody that's following, all these dots represent the people that are moving slower than 1.2 meters per second. So, before, if you're moving across the street, you need to be moving at that rate before the light goes from green to red. So a lot of these people are not really even making it across a busy intersection before the light turns red again. And so that's a sign that this gait speed is very slow. And even in the younger adult groups, we're seeing some slowness there as well. And so there's a need for interventions, and really in both age groups, to be honest. Next slide. So the conclusion, since that was a pilot study, was really focused on, is it feasible to do this assessment in people with sickle cell disease? And we found that it is feasible. It was acceptable, and it was safe, and nobody got hurt, doing all this battery of physical assessment, and also looking at some of the other areas of health as well. And it was acceptable. We were able to identify functional impairment and derive an equivalent functional age, which we showed you in that graph. And click again. And we're also at this point working on validating the measures. So really figuring out what do these different measures tell us, right? Are they useful? Which ones are the most useful? And so that's kind of where we are with things. Next slide. Next slide. So let's talk about frailty. So some of you may already know what frailty is, but I want to talk to people that don't know what frailty is. And so frailty is an age-related syndrome. So it's something that we think about in older adults. And so it really just is talking about your increased risk of vulnerability to adverse outcomes. So things like hospitalization, right? Things like death, like age-related risk. These are things that's focusing on your age-related risk of some of these badness happening, right? How vulnerable are you? So like I said, frail people that are categorized as frail are really at risk of major declines in function, even just in response to mild events. And so example of that would be, you have two different people, they both get hospitalized. The frail person may really take a hit and really just end up being really debilitated after that hospitalization, versus the more robust person can bounce back a lot faster. They may do a lot better after taking a stressor, like having an adverse event, like getting hospitalized or some kind of major event happening, or having an acute chest or something like that. So, you know, the frail person will take longer to come back after that. Being frail increases your risk of being disabled, being hospitalized, ending up in a long-term care facility, and increasing your risk of death. So it's important to know who's frail and who's not frail. And so a lot of the markers of frailty include age-related associated declines in your lean body mass, right? So if you think about how to categorize frailty, they use a lot of these different concepts of, you know, losing your body mass, like losing weight, losing your strength, losing your endurance, having less balance, you know, having slower walking, having less activity. So these are things that are really associated with frailty and really make up of what we call frailty. And so that's really how this idea of this frailty phenotype came to be, right? Thinking about the things that really make up frailty, they came up with this way of measuring, and this is Linda Fried at Hopkins. She developed this this was published in 2001. And basically, you're looking at 5 different areas of health that make up frailty. And if a person meets a 3 or more out of 5 of these different things, they will be categorized as being frail. And these 5 things are having unintentional weight loss of 10 or more pounds in the last year, having self-reported exhaustion by a questionnaire, just 2 questions, and reporting that they're having trouble getting going, that kind of exhaustion. Having weakness by measuring their grip strength. So this is actually a test that they have to do and squeeze and see how strong they are. Having slow walking, so having a slow usual gait speed, and this is a physical performance test as well. And having low physical activity by survey. And so if you have 3 out of 5, then you're frail. If you have 1 to 2, then you're pre-frail, which is still a risk. But having meeting none of these criteria, you will be categorized as robust. Next slide. And so just like I mentioned, you know, that being categorized as frailty is associated with adverse outcomes. And this graph is really just measuring the risk of death based up by group. And so as you can see, the people in the lowest line are frail people, and so they're higher risk of death. But people even in the intermediate category have a higher risk of death compared to robust. So that really shows us that even being in the intermediate group, meeting 1 to 2 criteria, is still something we should pay attention to, so that we can think about interventions early and not wait till a person's categorized as frail before we start thinking about doing stuff about it. Next slide. And so one of the things we did is we measured it, right? We've been measuring frailty phenotype in our people with sickle cell disease to figure out, is this a useful construct for our patients, right? You know, frailty is something that's studied in people 65 and older in the general population, but it really is not focused on people with sickle cell disease. So it's an ongoing study we have. This is some preliminary data on our current patients. Right now we're at like 70 patients, but this was some early assessment of the frailty phenotype in our people with sickle cell. So this was just looking at 28 people. We found that majority of them were able to complete all components of the frailty phenotype assessment. So it's pretty easy to do. All the measures were found acceptable. No one really said it was hard to do, and it was not upsetting. No items were upsetting, and there was no adverse effects. Nobody fell. Nobody got hospitalized after measuring this. Majority of them were female. So we had a lot of females that were in this group, and a lot of older adults. And part of that's because a lot of the focus of our work tends to be on people age 40 and older. So they tend to be recruited more for our studies. And so the mean age of the participants were 46, and majority of them had a severe genotype of SS or S beta 0. Next slide. And when we look at the breakdown of the different criteria that we talked about, so those 5 different criteria of weakness, you know, by grip strength, slowness by gait speed, weight loss by the questionnaire, physical activity by questionnaire, and exhaustion by the 2-item questionnaire, we find that no participants met criteria for weakness by seated grip strength, at least in this early preliminary analysis, and nobody met criteria for slowness by the preliminary analysis and using usual gait speed. And part of that is because the criteria that's used in the geriatric literature is pretty low. You know, so as I've mentioned, to cross an intersection, you need to be moving at about 1.2 meters per second. The criteria for frailty here is 0.8 meters per second. So that's a really slow, bar to meet, and most participants were able to meet at least the 0.8 meters per second bar for that. And 15% of people met criteria for unintentional weight loss, and the same goes for physical activity. And that physical activity is really just a questionnaire that's asking about energy expenditure. It allows us to calculate how much energy a person is expending every week based on like how much they're working, how much they're exercising, and we basically calculate how much kcals per week that they are expending. And so about 50% of people were low for that, so they're more sedentary. And the people that did meet criteria for pre-frail tend to meet it due to exhaustion. So a lot of people said that they were exhausted by the questionnaire, and so even meeting 1 out of the 5 criteria does put you in a pre-frail category. Next slide. And so this just talks about, the different breakdowns. So only 1 person out of the first 28 people that we looked at this in met full criteria for frailty, because as mentioned, the bar is low, right? And so pre-frail, majority of people actually met it, and that's really due to that exhaustion. And then there were quite a bit of people that were robust. Click. So when we compared, I lumped them together with pre-frail in one group and robust in the other group. And I wanted to know, what's the difference between robust and being pre-frail and frail? And so, and looking at the differences, we noticed that people that are in the pre-frail group tend to have a lower 6-minute walk distance, which is not surprising, right? So, even though the gait speed, really kind of wasn't picking that up, but if you look at the people that met criteria for being pre-frail and frail, they were walking much slower based on their 6-minute walk. The other thing we found is that hospitalization. So people that were in the frail pre-frail were more likely to have reported being hospitalized in the last year. And looking at some of the other demographic measures like age, income, employment status, and hemoglobin, there wasn't a difference between being frail, pre-frail versus robust. Next slide. And so even just thinking about like what do you do about frailty, right? What do geriatricians do about frailty? And so this is just a kind of a rundown of some of the things that are done to manage frailty, accelerated aging, and some of these geriatric syndromes. And one of the first steps is to assess, right? To do a comprehensive, holistic medical review using a geriatric assessment. So really just thinking about all these areas of health as I discussed and as we're developing for sickle cell disease. So you need to know, where do the deficits lie? How do I intervene in the first place? Where do I focus my attention? And so step 2 is to diagnose these things, right? And optimize the treatment of even just the medical condition. So, right, it's not enough to just think about some of these areas of health, but to think about, how am I managing the sickle cell disease itself? How am I modifying the disease, and how am I modifying the non-sickle cell problems as well? And so thinking about all these things together. Next, step 3, looking at the medications, thinking about polypharmacy, right? Are we giving inappropriate medications that can make people feel more frail and exhausted? And are we contributing to the exhaustion, right, as medical providers? And so, and making sure that medications that should have been adjusted or removed are off the patient's med list. And step 4 is looking at the impact of health issues and having a conversation with the patient and the caregiver to figure out, what are your goals as a patient? What are your goals for your life, right? It may not be the same thing that we as providers think the goal is, but maybe a patient has another goal. Like, I want to live long enough to see my grandchildren, get married. I don't know, whatever the goal, there may be a goal. Oh, I want to be able to go to the beach 2 times a year, right? And I want to be able to drive to do that, right? And so just thinking about whatever the goal the patients are having, and making sure that we're aligned as providers and patients. And step 5 is really just thinking about individualized, tailored interventions, right, that can preserve independence and function, right? So think about, how can I allow you to keep doing the things you like to do, as those patients talked about, as those participants talked about in that focus group. You're thinking about how they adjusted their lives so that they can keep doing the things they love, and how you can minimize hospitalizations. And so some of the individualized interventions that have been done are things like exercise, nutritional interventions, and these things have been shown to improve survival. Next slide. So let's talk about these individualized interventions. So we're also doing a study looking at exercise in older adults, so and really age 40 and up. And and this study is called the Sickle Fit study, and it's adapted from an existing study that is done, a program that's used in geriatrics called GeroFit. And just to give you a background on what GeroFit is, if you don't already know, is that GeroFit is an exercise and health promotion program that started at the VA. So it's actually just focused on veterans. So the original GeroFit program, and it was developed in the 1980s, and it was really focused on people that are at high risk of premature functional decline. So people that had chronic diseases, people that were deconditioned. It was really, people that were needing to use like assist devices like canes and stuff like that, and walkers, and really trying to get people that normally don't exercise, and how can we get them exercising, right? And so it's not necessarily something like a PT, like physical therapy. It's more about promoting health and really getting you to exercise even before you have like a injury, or you're getting physical therapy for some kind of complaint. So it's just focused on and getting you to exercise and promoting your health ahead of time. And so the goal is really just to improve function, making progress towards meeting national recommended guidelines. So exercising 3 days a week. So national guidelines say if you can exercise 150 minutes a week at moderate intensity, then you're doing a great job for your health, and you're less likely to die, right? The more you exercise, the more you move, the less likely you are to die. There's evidence that supports that. And so the original GeroFit was mainly facility based. So it was done out of a gym. It's still done out of a gym now. And this is a program that's been ongoing since the 1980s, and it's still been disseminated in about over 30 centers across the country. And so it's a great program. It continues 3 days a week. They used to have a virtual portion of that in person that was focused on rural population that couldn't make it to the center. So it started off doing virtual just for rural people. During COVID, they ended up expanding the virtual aspect of it because people couldn't exercise in person anymore during the pandemic. And so that virtual piece ended up expanding, and lots of people were able to participate, and they were really able to optimize this virtual aspect of GeroFit. And a lot of patients prefer the virtual aspect of it. And so GeroFit is an ongoing program, and people are typically measured at baseline, at 3 months, at 6 months, at 12 months, and then yearly thereafter. And then, like I said, the focus really is to make sure that there's some individualization of the program and really personalizing it for each person's level of function. And so there's a group-based aspect of some of it. And where there's live personalization, where some people may be doing a chair version, some maybe people be doing a standing version, and there's some mobility aspect, there's some Tai Chi, there's dancing, and so some of the outcomes that have been shown and have been studied in GeroFit is improvement in physical function, right? We want to know first and foremost, can I improve the way someone's functioning? And they show that physical function improves, and it can even be maintained even at 5 years of follow-up. Quality of life improves with exercise with the GeroFit program. And then they looked at 10-year survival. 10-year, and 25% of people experienced a survival benefit that remained in the program. Patients were satisfied with the program, majority of people. There was this compression of morbidity, so meaning the delay of a need for institutionalization or assistive care. People felt more socially connected, so there was social support, and there was some mental health improvement as well in this program because there's a group aspect of it as well. And so, and exercise itself has been shown to improve mental health. Next slide. And so we have been adapting that for sickle cell disease. So this is one of the programs that's funded through the American Society of Hematology, where we've been doing this, where we've been adapting this same GeroFit program, personalizing it for people with sickle cell disease to address the functional impairment that we identified using that sickle cell disease functional assessment tool. And we focus on people age 40 and up. Next slide. And so, so this is the design of the current study that we've been doing now. And so, like I mentioned, there's this tele video virtual aspect of GeroFit that really is the focus of the way we are doing this. And so we call our program Sickle Fit. So if you hear me say Sickle Fit, that's basically our sickle cell exercise program that's focused on people age 40 and up. The duration of each group. So we have 4 different groups that they don't run at the same time. They run one after the other. And so the goal of that is that we have these series of these different groups, and that we optimize we get feedback from the coach that's teaching and the participant, and we're really trying to make it better and finding ways that how can we make it safer, how can we make it better after every cohort. And each cohort has about 5 to 8 participants that participate by Zoom and that exercise 3 days a week. And so some of the components of the exercise program are starting off with warm up, cardio, strength, balance. So they really just start off getting warmed up. The intensity of the exercise is determined by patients. So the participants will give a rating. They'll give a rate of their exertion. So every day they exercise, we ask them, what is your RPE, what is your rating of perceived exertion? So 0 being very easy, 10 being very hard. And we really don't want people going up to a 9, right? We really want to keep that around 7, keeping that around 6, so that they're not overexerting themselves and they stay in that moderate intensity range. Then each exercise really starts off lower in intensity and lower in duration, so to make sure that people are safe, they're not having pain crises, and that they stay in the program. And so far, we haven't had anybody hospitalized. We're doing pretty good. We're just in our first cohort, and people are, rating the program as high, and they're very happy with it. Some people are giving us 10 out of 10 ratings, and people are surprised because in the past, some people who couldn't exercise or thought they couldn't exercise are actually able to do it now, is because we're doing this slow, starting low intensity, lower duration, and gradually working them up each time. Next slide. And so just to give you the inclusion criteria, so people have to have sickle cell disease, because it's only for people with sickle cell disease that have a confirmed diagnosis. They have to speak English, because the coach and the people that are giving them instruction only speak English, and maybe we'll have a Spanish-speaking version for in the future. The exclusion, and so just because this is kind of our first time, doing this and focusing on exercising people 40 and up, we really are kind of strict about the exclusion criteria. And so, we want people to self-consent. We want people to volunteer to be in this themselves. So we're excluding people that can't consent themselves. So people with moderate and severe cognitive impairment, they have a diagnosis of it, or their normal sickle cell provider tells us that they're severely cognitive impaired. And that's also the criteria that's used in Gerald Fit exclusion criteria as well. Like I said, people that can't consent themselves, people that are wheelchair bound, because there's a lot of standing, and some people can do exercise in the chair, but at least in this initial group, we're focused on people that are not wheelchair bound. People that are already cured from sickle cell disease are not in this study, so we're only focused on people that actually still have active disease. If people they can't see, because this is a virtual program, and so they need to be able to see the screen, they need to be able to hear the instructor. So we can't currently this program can't have people that have that can't hear. They can have hearing loss, but it needs to be at least corrected, right? And so people that are on oxygen are not in the program. We don't have pregnant people. We don't have people that that's avian that's so severe that they have to use like a cane or a walker. And people that have had like heart attack or unstable cardiac disease are not in the program. Next one. And so as people are in this program, we're also collecting data on how they're doing. So there are 4 time points where we collect data. So at baseline, so before they start the program, we do like a full functional assessment. And in addition in that is checking their balance, their core strength as well. We check their function again at the end of 12 weeks. And then we also check it at 6 months and then 9 months. Every 2 weeks, we get feedback on how the program is to them. How's it going? How do you think things are? Are there things that we can do to make it better for you, to make it, if we're not addressing some of the AVN, how can we make it easier for you to move despite having avascular necrosis? And then at the end of each cohort, we do a focus group to really get all the participants together and to give us really good feedback, so that we apply the feedback we get for the next cohort, so that it gets better and better after each cohort. Next slide. So some of the endpoints that we're looking at really is just feasibility. So we really want to know, like, is this possible? Is it safe, right? Is it acceptable to do this in people with sickle cell disease age 40 and up? And so, our goal is that we want at least 80% of people to pretend at least half of the session so that they can be getting some kind of benefit out of it. And so we're looking at attendance every time. We're also looking at reasons for people when they don't attend. So we want to know, like, why wouldn't a person attend? And so some of the reasons so far people have missed classes are, if they feel sick that day, like, somebody had a GI bug, and it's not really because people have, so far no one has missed because of a crisis. But like I said, we're still in the first group. We're also measuring number of major or life-threatening events that happen after the exercise session. So we don't want people to develop acute chest after exercising with us, right? So and if that happens, that tells us we need to do something different, right? That may not be safe. But so far, nobody has had that. And we want to know, is this acceptable? So we have like a satisfaction survey that's at the end of of each cohort that asks, how did it go? And then exploratory outcomes like changes in physical performance. Next slide. So this is our study team. So we have lots of people that really have helped to contribute to the work that we do. And so, my primary mentor is Dr. J.J. Strauss. We have a nice research team of lots of talented people. Arvin, Stephanie, Rania, Rena, I'm going to say all their names. Tegan, they're all doing a good job. Tegan is our exercise expert that coaches the class. And then we have our patient advisor, our master advisor, Veronica Mathis, who's an ICU nurse, and she also has sickle cell disease, and she really has provided a lot of input for how we design some of these aging studies. So even the sickle fit study and the functional assessment study, she provides input on how we can make these things better. We have lots of mentors in the Aging Center, the Duke Center for Aging, that have helped us to design the geriatric functional assessment and figuring out how do we tailor this for our population. Harvey Cohen, Heather Winston, Regina Crawford has been great mentor, and people that study health equity like Kimberly Johnson have provided a lot of input for that as well. Betty Pace, for those who already know, has just been incredible for even just my career development through the PRIDE program. So this is some of the funding. So the Center for Research to Advance Healthcare Equity has been funding some of this work over the last 2 years. The NIA through the Gemstar Award and the PRIDE program. And then our Pepper Centers is one of our programs in the Aging Center. And at the bottom, you see a lot of our Aging Center. So Miriam Morey was the person who developed GeroFit in the 1980s, along with Harvey Cohen. And so these are our mentors that are helping to adapt this stuff for people with sickle cell disease. And then we have Dr. Tellen, Marilyn Tellen, our statisticians, our experts here that have been great in helping us analyze a lot of this data. And I will open the floor for some questions.
Absolutely. Thank you so much, Dr. Charity. I found that extremely interesting and informative myself, and I'm just already knowing that others did as well. At this time, we will begin taking all participant questions. As a reminder, the way to submit your questions is through either the chat box or the question function on the control panel feature for this webinar. And so with that, we'll get started looking and seeing what kind of questions we have, and I'll turn it over to Jackie to facilitate that.
Thank you, Niani, and thank you, Dr. Oyedeji. That was really informative. I don't know too much about the older adult population, so this was a lot of new information for me. Just something that I have jotted down quite a few questions, but as people kind of send those in, I have a question. There was a slide way in the very beginning when you were talking about the functional assessment study, and I noticed that there were some differences between the males and females, with the females doing kind of quite a bit better than the males in the group. And have you guys looked into that, or can you talk a little bit more about that?
Yeah. I mean, we typically, I wouldn't necessarily say the females are doing necessarily better than the males. I think, our age, everything is really adjusted for age and gender. And so I tend to really look at the genders separately rather than comparison, because it's really, you can't really compare physical performance males against females. And so, when it comes to analyzing this, I tend to just analyze the males against the males in the general population. And so that's kind of how I would think about it, rather than one against the other. But, in overall in sickle cell disease, we do see, women outliving men in general, in women with sickle cell disease. women, and that goes the same in the general population. The other part is that a lot of our older adult women tend to come to clinic a lot more too, and so they have more access to disease modifying therapies. And so as you can see, like in our study, we tend to have more older women than males. So I think that there's two reasons that that survival is better for women, and then women are just really tend to engage in care a lot more as well.
Thank you. Actually, you make a really good point about not comparing the males against the females, and it's really interesting. We just got another question in, so let me just try to actually see that. This question says, amazing job, thanks for sharing. I'm not sure if physical therapists are part or if they should be part of the comprehensive care of the sickle cell disease patients. Is there a role for physical therapists in the care of SCD patients?
100%, absolutely. And we have research studies that are ongoing with physical therapists in our group, and so absolutely there's a very strong role. And so as we are validating a lot of these the sickle cell disease functional assessment, a part of it is including the input of stakeholders like physical therapists that really do play a very important role in this. And so when it comes to exercise intervention, though, they tend to be physical therapy is a little different than an exercise program, because physical therapy is all about, you have this issue and how can I focus on this issue and help that thing be made better, versus an exercise program or health promotion program that's really just focused on how can we make how can we just keep you better, right? Just like exercise, right? You're doing this exercise before the problem even comes, right? How can I improve your endurance? How can I improve your function, your strength, your balance, even before you even present with an issue? But so a physical therapist is thinking more about the deficit that when we refer them for when patients are having unique issues like AVN in the hip and thinking about that area. But yes, they play a very important role.
Great. So coming back to your the functional assessment and the frailty assessments, when do you use one over the other? How do you choose which assessment you want to kind of utilize, or do you utilize both of them?
Yeah, so I think so the frailty assessment is a lot shorter. It's just 5 items, right? And we're currently in the process of figuring out which of even in the comprehensive functional assessment, which components of that is the most informative for us. And so I think a comprehensive assessment can be performed annually, but maybe broken up into parts, because the comprehensive sickle cell disease functional assessment takes a while. You're talking about maybe an hour, sometimes a little longer in its current state, because we're still trying to trim it down and figure out which parts of it are the most informative for our population. Because we pulled it off the shelf as it's used in geriatrics, and it might not be as beneficial in the way it's currently being used for geriatric populations. And I do think there's some modifications, and even the cut points need to be different for people with sickle cell disease. So, and that is still something we're figuring out. But a frailty assessment is short. It's a frailty phenotype, right? There's many ways to measure frailty. The frailty phenotype is just the most common way it's done, and that's quick. You were talking about you're getting a gait speed, you're getting a grip strength, and you're doing 3 questionnaires. And so that's a quick way of knowing how frail somebody is. And so I will say this, that frailty is kind of an end stage. When you say somebody's frail, right, their gait speed is really slow, their energy expenditure is really low, their strength is pretty low. And so like I said, like the thresholds for that are very low. So if you wait till somebody's frail, then you're kind of catching them at the end. And so I think if you really just want to get an idea of how somebody's doing a full sickle cell disease functional assessment would be a better thing to really start off with, so you don't really capture people when they're at the end stage of their functioning, right? And that's when you start it. But knowing if somebody's pre-frail is still a very useful thing, but we don't really know kind of like how what to do about a pre-frail person yet in sickle cell disease. So like I said, a lot of this is still like in a research program, right? They're not live yet, used in a typical clinical visit yet, until we kind of tease things out. But I will say frailty is kind of an end stage thing, in that you really don't want to wait so long till somebody's frail before you start doing things. And the other part too, I will say too, is that frailty doesn't tell you about all the other dimensions, right? It doesn't really give you a full idea of their like mental health. It doesn't give you a full idea of their social support, their nutrition. It really doesn't give you that full idea. The frailty is just really just a way of categorizing, people by their risk of adverse outcomes in the future. So really that comprehensive assessment is really important when you're thinking about developing a multidisciplinary management plan. And so it's really important to do the full functional assessment, but even if you broke it up into parts.
Great. And is part of your continued research to kind of have an age of when to start doing the functional assessments and not waiting until they're like over 50?
Exactly right. And typically like in geriatric populations, they have a cutoff of like 65 and up, right? And so, I think there should be a cutoff, but I do think that anybody really can benefit from knowing where their deficits lie. The only problem is that, when it comes to validating these things are being validated by the age group. So, by the 40 and up, we're going to be able to say these are the cut points that are used in the 40 group. The advantage of us also having a young adult group, I'm hearing some feedback. But yeah, the advantage of having a young adult group is that we also can understand what are the points for the younger group too. So we might find that it's useful even for young adults as well. But so far, we're really focused on saying 40 and up for just like how in the geriatric population they use 65 and up.
Thank you. And a question from Dr. Hager, and are you assuming that all of the differences in functional assessment are differences in sickle cell disease activity?
Say that again.
Are you assuming that all of the differences in functional assessment is from differences in sickle cell disease activity?
I don't think so. I don't think so. I think that's part of the story, but I do think, when you have a person that is susceptible to not just, can you guys hear me okay? Jackie, can you hear me okay?
I can hear you okay.
It's now a little choppy.
Say that again?
Everyone can. It is a little choppy.
Yeah, because I'm not hearing too well. Can you hear me now?
Yes.
Okay, so like I said, a person is susceptible to their sickle cell conditions, but they're also a person like any other person, right? And so they're susceptible to things like, I was just in clinic today, and even though this person has sickle cell disease, they can have lumbar stenosis, they can have, diabetes, they can have all these different things because as you get older, you can acquire non-sickle cell disease related issues, and you're susceptible to just the things that happen with aging. And there are some hallmarks of aging that just happen to everybody, regardless of how you're categorized, what kind of background disease you have. But there are things that happen with aging, like inflammation. You get more inflammation as you get older. You may have a change in how you're sensing nutrients. Your ability to sense different nutrients changes. Your gut changes as you get older. Your mitochondria, all these different things are changing as you age. And so there is a multi-component part of functioning, right, that happens. Your muscles, you may develop sarcopenia as you get older, and so your muscle mass changes, right? Your physiology changes as you get older, and this is every human, right? And it may happen at different rates, right? Your chronological age doesn't tell you how fast this happens, so maybe there's a possibility in sickle cell disease, some of these things that are natural parts of aging could be happening at a faster rate. But then you have sickle cell disease itself, and so there's a multi-factorial component to functioning that I think is playing a role. And so if we just took sarcopenia alone, right, that's something that is affected by sickle cell disease and just affected by aging itself, right? Your testosterone levels can drop as you get older, and that affects your muscle mass. That may not necessarily be a sickle cell thing that happens in the general population. Estrogen levels, all these things change, and so it's a multifactorial thing.
I'm going to jump in real quick, Jackie. I'm seeing sorry about that. Seeing another set of questions. I want to try to get to a few more. Someone's asking, how can we implement a geril fit or Sickle Fit program in Southern California, and I guess that would also go across the state. You know, any thoughts on how someone could get started with something like this?
I mean, we plan to eventually have it to be like a multifactorial program where we collaborate with people at different places. Like once we, get through this initial portion, we plan to collaborate with different investigators and really try to, because it's virtual, right? And so it makes it easy, but you want to make sure that the secret sauce of GeroFit, right, can be implemented across. And so like when, GeroFit has like has like a method in which they kind of implement new programs. And so it would be good to kind of team together with other programs so that implementation can be more standardized, right? And so that fidelity can be maintained, right? So that the program can be the same. If you really, it's going to be, if we're talking about adapting GeroFit. And so really it comes, and so the way we, for example, how we started is that we basically integrated with GeroFit in the beginning, right? Because we wanted the coach to make sure that the coach fully understood the way GeroFit worked, how to exercise with an older adult, how to modify. And so really just spending time with the program, the coach being taught how to properly do it, and making sure just like even just the assessments that are used are being done in the right way. And so I think the best model might be kind of like a collaboration part. And so, eventually, my hope is that in the next, few years we will get there. But I would say the best way, and I think there's a lot of GeroFits, and so it might be possible to even collaborate with a local VA if you didn't want to wait for us to create like a multi-center study of this. But the goal, ultimately is to turn this into kind of a multi-center study where we collaborate with, PIs at other centers.
Great, thank you so much.
Then we have a question, and I may need some more clarification on this, but the question was, this is thinking about their patient population. I believe there are more ineligible patients than eligible patients, and many of them are not just motivated, not because they are disabled. What is the ratio of eligible patients to those who actually signed up? And I'm not sure which specific study this one might be referring to, but.
I mean, we're in our first cohort, and so I honestly will say most people are eligible. Most people are eligible. I mean, this is still very early, and so I'm probably, I would say if you were to say out of 10, maybe 2 become ineligible. It's actually not hard to meet eligibility. Most of our patients are not wheelchair bound, right? They come to clinic, they're able to walk most of the time. And we're saying wheelchair bound. We're not just saying coming in a wheelchair. We're saying that you need to be 100% of the time in a wheelchair. And that's not a common thing in our population. Most people are able to get up at least a little bit of the time. And we really push the boundaries, right? I always ask people, do you think you can get out of that chair? Like I really push the bounds as far as possible on who can participate. And if somebody is not currently maybe optimized, we try to optimize them, right? Like, is there an unstable, and you just remember, people with sickle cell don't commonly have like heart attacks. It's not necessarily a common thing as it is in the general population. So there's not a lot of people that have like an unstable angina, unstable like heart condition. And if it was unstable, we can get it stabilized by, seeing their cardiologist, making sure they don't have like an arrhythmia. And it's all about safety, right? You just want to make sure they're safe before they're going in. And if you think about someone's clinic, how many people are oxygen dependent? It's not a common, I would say the majority of people that come to clinic are not using oxygen on a daily basis. And so I would say most people are eligible. I think the hardest part is people finding the time to exercise. And so I think rarely are people ineligible. I would say the people that weren't ineligible are people that are using oxygen, that are oxygen dependent. And so far that's only been one person that I've had to exclude because he's using oxygen all day. And so and then as far as people being able to delay, I think the time of the exercise is what makes people kind of not necessarily be ineligible, but just move into a different cohort. So if someone is having trouble exercising at the time that we're currently in the class, we say, okay, we'll put you in cohort number 2, where they will exercise at 5 o'clock after hours so that you can exercise after work. And so I think the timing of getting the group to virtually exercise is probably the harder part than eligibility.
Gotcha. Great question. We have another one about do you know if there are any physicians or hematologists with a focus on patients with sickle cell disease who are over 60?
No other human. I think there are a few aging experts around. I think it's a growing area that we've been studying. I see a lot of patients over 60 in my clinic. And we have quite a bit of people in our study. I've been doing sickle cell disease functional assessments for a few years, and so I've met quite a. My focus at the beginning of the study was people over 50, and so we had quite a bit of people in their 60s. Like currently, we have people in their 70s. We have one person in their 80s that we recently included in our program. And so, you'd be surprised. We do have quite a few 60-year-olds, 70-year-olds that are in our program. So I would say I'm one of them. And then there's people that are studying aging at the NIH. There's NIH investigators that are studying aging. At UNC, there's an investigator there that's studying aging. And so, it's a growing area, and there are a few people. And even just in the literature, just looking at some of the papers that are written about older adults. If you type in sickle cell in the older adults, you're going to see a few publications about older adults from different investigators. I think Alice Cohen has written a paper, and Samir Ballas and Sui Lathin has written a paper. So there's few people that are doing aging.
I do see a comment that there is a over 50 clinic in Oakland, California as well.
Oh, Oakland, okay. Now we're talking about Oakland. I don't think so. I'm not aware of one. Let me phrase it in a safe way. I am not aware. It doesn't mean that it doesn't exist. It means that I just don't know. And maybe we need to develop some kind of consortium so that we know who all exists, because that's such a great question. Are there, to know like who are the, geriatric sickle cell doctors? I don't know. I know people don't like geriatrics, so but aging sickle cell doctors. Let me use a more safe word.
Okay, we have a couple more comments and questions. Let's see if I get there. One is, will you consider doing future cohorts that engage younger adults given the numbers presented?
I know. I think about it all the time, but I don't know if you guys have. I think y'all had a presentation by Joy Ogunsile, but she really focuses more on like the young adult group. So I see myself more collaborating with people that are already doing that work. Because Robert Liam is already focused on more pediatric populations, and Joy Ogunsile. I see more so partnering with people that are more focused on that, because it's better to focus, right? And to really focus on optimizing that. But I think I'm definitely excited about the idea of collaborating with people that are already in the young group.
Okay, a few more, and to answer somebody's question on yes, this slide deck will be shared. I think we have a comment from Sheila Marchbanks at Loma Linda University Health, just noting that there are several facilities in Southern California which may be candidates for expansion, I believe, for the sickle bit.
I'm really having trouble. Yeah, can you say that again?
Can you hear me okay now?
It's breaking up quite a bit. I'm struggling to hear you.
Nanny, are you able to hear me?
I can barely make it out. It's a little digital and choppy.
Okay, can you take over on the questions while I try to figure this out?
Sure. Give me 1 second. Okay. Are you able to hear me okay?
I can hear you fine.
Okay. Let's see. Just a moment to find the question she was at. I don't think I'm quite seeing that question, so I'm going to go with another one, and then we can hop back to that. Someone asked if body mass was adjusted for when comparing young SCD affected to the older because of their because of known increased obesity in our young adults compared to over 50 years old.
No, we didn't adjust for body mass. But one of the things that we're finding is that the older adult group actually is having higher body mass. And we actually just published a paper about that. Is that age, being of older age, was associated with obesity and overweight status. And so that's, we previously may have thought that, that the older you get, maybe your body mass is going down. But, in the SCDIC, cohort, age, was a factor. And so of people that are having higher body mass. And so I don't, there's not necessarily a need for that. There might be a need to adjust for BMI when thinking about grip strength, though. And so there are some formulas that can be used where you develop cut points based on body mass index, or based on weight. I would say like energy expenditure is also adjusted for weight, because that definitely, that's dependent on your weight in kilograms. Now, but when comparing older and younger, no, we didn't do that, because we were more so comparing it to norms. We were looking at how do people at this age group compare to what's expected for their age.
I see. Wonderful. Thank you so much for that. I do see a couple more questions, and it's all mixed in with lots and lots of praise for you. So what I'm going to do, since we're coming upon our time that we have allocated for this session, is make sure that I forward all of this information and feedback over to you. As folks know, feel free to continue to ask questions as well, and I will make sure that they get over to our speaker. I think, Jackie, are you trying to hop in there?
So are you gonna message them to me, or what are?
Yeah, I'll email them to you.
Okay, sounds good.
Yeah, I'll email them to you separately. So everyone, folks who have submitted questions that we weren't able to get to yours, I will email them over separately with your contact information and email, and make sure that I get some responses to you guys. And then just wrapping up here, this is how you can find out more information about our webinars, the work that we're doing, get plugged in and connected with our trackingcalifornia.org website, as well as our CA sickle cell .org is where we often post a lot of our webinars. We also have our social media at California Sickle Cell and the Sickle Cell resource page. And hello, can you all hear me?
Yes.
Oh, okay. Apologies. My audio cut out for a second there. So those are the best ways to find us. I want to, again, thank you so much, Dr. Oyedeji, for your presentation. Jackie, I'm going to give you a moment to see if you're back connected and had any final wrap-up points.
Hi, hopefully you can hear me now.
Yes,
maybe.
A lot better.
Oh, great. Okay, no wrap-up points, but thank you again, Dr. Oyedeji. It was really great information, and we will definitely follow up with any kind of outstanding questions we have. And thanks to everyone for joining us today.
Absolutely. And last but certainly not least, upon exiting this webinar, there'll be a brief 3-question survey where you can provide feedback about the webinar, ask additional questions, and suggest future speakers. So please take a moment to fill that out. We'd greatly appreciate it. I thank everyone for their time and participation in joining us today, and we will talk to you all next quarter. Thanks, everyone. Have a great day.